Okay, good morning, good afternoon, or good evening, wherever you're joining us from. Thanks for taking the time. We're just going to wait 1 minute to allow others to join, and then we'll get started. Thank you. Okay, well, welcome everyone to the Global Brain Health Clinical Exchange platform. This is an interactive and international collaborative effort to advance our understanding and clinical management of brain health. Please do type in the chat when you join us where you're from. We're able to deliver this thanks to funding from the WHO Brain Health Unit, the Policy Fund, and with the great support of the Global Health Network. And without further ado, it's great pleasure to invite Professor Ericka Fink to chair this session on what I think arguably has been underappreciated in terms of the impact of the pandemic, and that's pediatric neurology. Professor Fink, thank you for chairing this.
Thank you so very much. We're really happy to be here to present the first pediatric NeuroCOVID focused Global Brain Health Clinical Exchange. Many thanks to you, Dr. Benedict, Dr. Michael, and your team at the Institute of Infection in Liverpool for providing this wonderful opportunity to showcase clinicians and patient cases from Central and South America. Hosting along with Dr. Pablo Vasquez Hoyas, Associate Professor of Peds Neurology and PICU at the Universidad Nacional de Colombia. And Dr. Juan Roa is Dr. Juan Roa is an associate professor at Universidad Nacional de Colombia, along with Dr. Hoyas, is also a member of the LARed network in Central and South America. Other speakers today are Drs. Michelle Schober and Courtney Robertson. They're pediatric intensivists, and along with me, a member of Pediatric Neurocritical Care Research Group and North American Research Network. Our agenda today begins with a brief overview of SARS-CoV-2 in pediatrics and neurologic manifestations, followed by an interactive case presentation session by Dr. Roa. And then we will be treated to one of 3 breakout rooms, either epidemiology, pathophysiology, or treatments. And finally, we'll return to the main session to discuss the main findings in the breakout sessions and for summaries and conclusions and future directions. 2 years into the pandemic, there have been 474 million cases of SARS-CoV-2 documented, along with 6.1 million deaths. Over 10.8 billion doses of vaccine have been distributed. However, we do not know how many millions of people have been experiencing new impairments in the short or long term due to the pandemic. Per UNICEF data, with 105 countries reporting on the left, children and adolescents under the age of 20 account for about 33% of the global population and 20% of the known cases of SARS-CoV-2. That's almost 100 million cases. Next, on the right, of 91 countries reporting on age and death, children and adolescents under the age of 20 account for 0.4% or 13,400 deaths, with 42% of those occurring under the age of 10. Using WHO classification, you could see that cases in this age group are twice as high in high-income countries versus other countries, possibly skewed by access to testing. Notably, children and adolescents experienced a higher proportion of deaths in low-income countries, however, at 1% of the deaths compared to low, middle, upper middle, and high-income countries. Keeping in mind that nearly 100 million children known to be infected by SARS-CoV-2, let's talk briefly about the general ways viruses can manifest neurologically. First, children can experience neurologic symptoms such as headache or altered mental status. Viruses may directly invade the CNS or evoke parainfectious responses such as Guillain-Barré, or exacerbate neurologic symptoms in children who have pre-existing neurologic disease. Next, children, especially those admitted to an ICU and exposed to hypoxia and low blood pressure, are at risk of post-intensive care syndrome, which are problems in later with function and health-related quality of life. And notably, Nearly all of these, except the direct CNS infection, have been reported in children with SARS-CoV-2. What neurologic symptoms are children experiencing with SARS-CoV-2 in particular? This study from the US from 61 centers and 1,700 children, 22% of children either with acute COVID-19 or MIS-C had neurologic manifestations, most importantly, fatigue and weakness, followed by altered awareness or confusion or headache. You could see there are differences by age. And our interim study of our GCS NeuroCOVID consortium of nearly 1,500 children who were hospitalized with COVID or MIS-C, 44% had neurologic manifestations reported in their chart review, most commonly headache, acute encephalopathy, or seizures. Neurologic manifestations were more common in older children, those with MIS-C, as opposed to acute COVID and pre-existing neurologic or metabolic conditions. I'm going to turn this over to Dr. Pablo.
Good morning, all. Thank you for the invitation again. So when we try to look at the epidemiology in Central and South America, well, in adults has been partially resolved because we're using excess deaths, which you don't need testing for it. But most of these countries also don't report excess deaths at a timely fashion. So most of the time, as you can see in this slide, we do an estimated cumulative excess death, which means that we are estimating, not measuring. As you can see throughout the world, South and Central America have a bigger percentage than most of the parts in Africa and Asia, but still it's very high. And you can see right away that two of the biggest places where we have seen this is Peru. And can you show the next slide, please? And from Central America, Mexico are the two main parts of the world where we have seen excess deaths. If we look at the, can you show me the next one, please? If you look at the excess mortality actually reported, you can see that most countries don't have these reports. But on those we have from South America, you see that Peru had 80% excess mortality in their country compared to other places in South America that we had as low as 4% in Uruguay, and most had around 20-30% excess deaths. Next slide, please. And from Central America, we also have some information, and the biggest one will be Mexico, that it's around 40%, which is similar to some places in South America. As you can see dates on the first panel, you see that most countries don't even have a close to 2021 report. The last ones are probably December 2020. So this information, it's actually a little bit outdated in some of the parts. Next slide, please. So when we think about pediatrics is more complicated because we only rely on testing, as excess mortality was not more important than regular mortality in this country. So we only can show either mortality or incidence. As you can see, mortality in South America is not reported for every country because of different ways of getting the information. But you can see here that Peru, that had a great burden of disease, also had a great mortality in children, which is consistent. And throughout South America, mortality was higher than reported in most places in the world, but it's a little bit closer to 20-30 cases per 100,000, which is pretty much around what happens with regular respiratory infections in children. And next slide.
Thank you so much. And Dr. Juan Roa is going to be presenting his cases next. And be ready to answer some polls.
Hi, thank you so much. Thank you so much for the invitation. I would like first to give you another view of how my practice is. My practice is mainly set in Bogota. Bogota is the capital city of Colombia. It's a 9 to 10 million people population. And also we have 1.9 children population in general. So my ICU is the biggest ICU in Bogota. It has 26 beds. It can be opened to 41. And in general, in Bogota, the capability of ICU beds is around 280 to 310. We also get kits for all over the country. Colombia is a 45 million population country. So this is kind of the scenario where we do our practice. Also, I would like to have these three cases. These three cases have been chosen because they gathered together the different neurological manifestations, severe neurological manifestations of COVID-19 in children. That's why we choose these three cases. So I will start with the first one. The first one is a 9-year-old girl with no past medical history. She was normal before the onset of the symptoms, but she started having headaches during 2 days, emesis and somnolence. For that reason, she consulted to the ER and she was sent home on acetaminophen with minor viral illness. But the symptoms continue, the headache increases, and also is accompanied by decreases of altered consciousness. That's why she consults again to the ER room. When she arrived to the ER room, she was hemodynamically stable, grade 1 dehydration and somnolence that progressed rapidly to stupor. Also, he was febrile at the beginning of the clinical symptoms. When we did a neurological exam on her, she was GSS 12, ocular 4, verbal 2, motor 6, no meningeal site, no papilla edema, and in general, and no focal neurological exam. This is the main clinical scenario. I would like to start with the questions. So one thing that I would like to people to understand is probably when we have this patient, we do have one scenario where we do what will be the optimal clinical testing or diagnosing test, but I would like the people to understand where they are located and what will be the diagnosis test that they'll use. I will translate it to Spanish too, so for the Spanish speakers, imagínense un cuadro clínico de una paciente previamente sana que ingresa a urgencias con alteración de conciencia. ¿Cuáles serían los diagnósticos que ustedes usarían en un caso como estos? ¿Qué exámenes diagnósticos usarían? So it will be A, blood markers of inflammation. It will be B, just electroencephalogram, EEG, brain MRI, or cerebrospinal fluid antibodies. Okay, so most of the people mark A, the lab diagnostics. That's the same thing that we did, mainly because of it's easier and it's probably cheaper to start with that. So what we did, can we show the next slide, please? What laboratory tests? One of the things that was remarkable for us was the mainly findings about inflammation, white blood cells elevated, who continue elevated during the first 3 days. Also a C-reactive protein, highly elevated, with a procalcitonin who was negative. So this was remarkable on probably not bacterial infection. Also we did ferritin. Ferritin is something that we start using a little bit more during the pandemics. And also D-dimer and fibrinogen, who was elevated. Also, because of the neurological symptoms, we did a CSF study who was not positive for infection with a film array on different pathogens of CNS. And also the PCR for SARS-CoV was positive in the 3rd day. In our hospital, we do have MRI, so that's why we did an MRI with no remarkable findings like you can see here. And also because we do have in hospital EEG normal monitoring, we did an EEG that showed this slowing background consisted with mild encephalopathy, but without epileptiform discharge or lateralizing signs. Okay, so the next question will be about the classification. So how would you try to classify this patient diagnosis? And one of the things that I would like to remark on this question is we talk about multisystem inflammatory syndrome, but multisystem inflammatory syndrome mainly in kids is associated with cardiovascular, pulmonary, or even gastrointestinal syndrome. But in this case, that we do have some serum markers of inflammation, and also we do have neurological findings. Would you say that this case will be a mild MIC or a moderate MIC, or probably a severe MIC, or not an MIC at all? So, pues, Spanish speaker, ¿ustedes creen es que este paciente puede ser un síndrome inflamatorio sistémico leve, moderado o severo, teniendo en cuenta que la clasificación y los criterios diagnósticos para síndrome inflamatorio multisistémico generalmente abarcan cuadros inflamatorios en exámenes de laboratorio, pero también principalmente alteraciones cardiovasculares y respiratorias? So I know we do have the pulse already. And I would like to clarify that probably the classification sometimes is not very well established, and most of the time what we do is we try to put them into different set of classifications according to our clinical perspective. So that's why we choose this question. So most of the people classify this as moderate MILC. So I did the same. So we did the same. Can you show the next one, please? And again, according to your normal treatment, to your clinical scenario, what treatment would you start with this patient? ¿Qué tratamiento usaría usted en este paciente de acuerdo al sitio donde usted practica normalmente? One thing that I'll point into this case is, like I showed, is just at the beginning of the clinical scenario in this patient. So now that we know what would be the complications for a patient who has neurological symptoms associated with COVID, and what we can do at this first step when you have this kid with 3 days of symptoms, but knowing that probably it can go to an immunological mediated disease or vascular disease or something like that, what would you do at the beginning? I know we have the results. So for most of the people, they start with steroids. Also, IVIG was another option, and symptomatic and observation. So this is for the first case. So I will go to the second case. The first one was mainly encephalopathy, and the second case is a 3-year-old male, previously healthy kid who arrives to the ICU with rapid paralysis, acute flaccid paralysis. So no significant past history. He has a normal kid with developmental milestone, just normal. And he started with acute ascending weakness, mainly in the lower extremities, associated with hyperreflexia, urinary retention, and also dysphagia. The progression was very fast, and it progressed to respiratory failure in terms of hours. So we have to start mechanical ventilation on him. Also, in terms of another, he was normal consciousness, no hemodynamic instability. So knowing this just clinical scenario and with these clinical symptoms, mainly associated with acute flaccid paralysis, and according to your normal epidemiology, what would be your main diagnosis in this kid? Entonces, para los en español, es un niño que tiene 3 años de edad, es normal previamente, y se presenta a la unidad de cuidado crítico por una rápida progresión de parálisis flácida aguda con predominio en miembros inferiores, hiporreflexia y un síntoma importante que es retención urinaria. ¿Cuál sería su diagnóstico en este caso? So for most of the people, it will be diagnosed with Guillain-Barré syndrome. Okay. What we did on him was we did start with a laboratory test. So was not remarkable in terms of inflammation, low ferritin, low the dimer, white blood cell was normal, kind of low a little bit. And we also did an LP. We did an approach for Guillain-Barré or transdermalitis. It was the approach that we did based on the clinical symptoms. And we also, because we do have oligoclonal bands and antibodies in CSF, but it came at day 10 negative. So it took us a lot to have those results, but we did it. And also a SARS-CoV PCR who was negative. We did an MRI on the third day of the clinical scenario, and we do have this anterior posterior enhanced of signal, and also increased volume, who was covering more than 3 different segments of the medullary core from T10 to L1, and also contrast enhancement in the roots of cauda equina. And with that results, and also with the clinical spectrum, what will be your choice of treatment in this case? So for Spanish speakers, hicimos la resonancia y la resonancia mostraba un aumento de la señal en la porción anteroposterior de la médula espinal, especialmente en los segmentos inferiores. Adicionalmente, un aumento del contraste en la cauda equina. Con esto, ¿qué tratamiento utilizaría usted en este paciente? This is an important question because some have, like we have here, we have high doses of steroids and also IVIG and plasma exchange. For us, IVIG can be sometimes difficult to have in some hospitals, and also we don't have the capability of doing plasma exchange in all the clinical scenarios in clinical settings in Colombia. So that will be a little complicated, but most of the people went with a high dose of steroids. And then I will go for the last case. The last case is also a 9-year-old girl with who presented to the ICU with right hemiparesis and central facial paralysis. When she arrived very early with the symptoms. The blood pressure was highly elevated. Heart rate and respiratory rate was normal, but we did an PET NIHSS who was 14, very high with alternating status, facial palsy, hemihypoesthesia, hemiparesis, and dysarthria. This was at the beginning. Previously to the admission, she recalled having mild respiratory symptoms, and also the mother has tested positive for COVID-19. We did a COVID-19 PCR on her, who was negative, but with IgM and negative, but IgG positive for according to a already previous infection of COVID-19. In terms of the past medical history, it was not remarkable. A normal kid with no varicella. She had the varicella vaccine and no other symptoms, no risk factors in terms of neurological previous diseases. The hematological and the autoimmune workup was the first approach to this kid came out negative with an echocardiogram and also another different test of cardiovascular function who came normal. Fibrinogen was a little bit elevated, but not that much. TMRD normal, and C-reactive protein, this value is normal for our hospital. So what we did an MRI. This is the 2 major findings: the restricted diffusion in the area according to middle cerebral artery, and we did angiography, who has these decreases on the diffusion of the contrast enhancement in kind of the talking us about cerebral arteriopathy, focal cerebral arteriopathy. So in this last patient, she arrived immediately after the start of the symptoms, and in your different hospital, what would be the treatment of choice for this patient? So, teniendo en cuenta un paciente que tiene unos síntomas neurológicos agudos compatibles con una lesión focal vascular que ingresa en periodo de ventana, ¿cuál sería en su hospital el tratamiento de elección? So for most of the people, it will be RTPA thrombolysis. Less, unfortunately, it has 20% of people, and we are on this group about the no availability of doing TPA that fast. And what would be your treatment of choice for follow-up in this kid? It would be antiaggregation, anticoagulation, steroids, immunomodulation, or combination of those. Entonces, ¿cuál sería el tratamiento que ustedes darían para seguimiento de esta paciente con un antecedente de un stroke agudo en el contexto de una infección por COVID-19? Most of the people will go for ANC, antiplatelet therapies, and steroids. That was the same treatment that we used on her, and also the clinical follow-up into her. So these are the three cases that we choose to present this today. Like I show you, it was one with encephalopathy, one with general encephalopathy, the other one immunological mediated disease, and the other one was vascular endothelial disease. Kind of the three different spectrums of what we can see and we can have seen during this time into COVID-19. I would like to the people to go to the different breakout rooms. So I don't know, Ericka, if you can send in there or what.
Yeah, thank you so much, Juan, for that really excellent summary of three challenging cases. And I think the polls were really interactive, and it's really interesting to see what, different people are able to do and what they would choose to do in these situations. I think that we're ready to go to our breakout rooms. Hi, everybody. It looks like we're getting back to the main room magically. Hope everyone can hear. All right. So in the next few minutes, I think it would be great to, since we had to each be in a separate room, talk about the key points that were made and key discussions that were made in each of the rooms. Let's start with Dr. Pablo on epidemiology.
Okay, so thank you again. So what I think it's important for us in epidemiology is to highlight that we really don't have good data in children, at least not in South America and Central America. Even I don't think we have good information throughout the world. Most countries had basic demographics, but here we need more clinical detailed information. So one of the key things is that we need to build networks for investigation on children for COVID. At least in our country, we have tried to do that with the help with the NHO and some other groups that had bigger infrastructures. So one of the things we used was mentoring, and that helped a lot, but we still have that information. It was not readily available to make decisions. So most people had to do on their own. And I think that was the main key point we found in epidemiology in children. I don't know if someone else felt something else. Or has
I think that yes, it seems like your country's leadership is if they find collection of data to be very to be very important. It takes leadership like that to really collect countrywide data like that, even if it's not 100% complete, especially by age, to show what the problem is in children, and also to look at health disparities and access to care and who's most at risk of infection or poor outcomes. Any other comments on that, Dr. Pablo?
Yeah, well, I think that our country did a great effort in gathering data. What I think will be our next step, at least for my country, was to drive attention into children, as most of the information was gathered as adults were gathering information. It was not specifically for children, and they didn't develop good ways of at least socializing this information to other parties. And as we saw the information, we didn't see enough changes or things happening around this information. We as pediatricians will love to have seen people changing or directing efforts to places. We did had a good experience. We had a big breakout in a city in the jungle, in the Amazon, and there we had a big display of the government, and they did a lot of testing, and they were able to contain this epidemic, and that had an impact in children as well. So we can do a lot of things with the information. So I think it's very important to have this as a first step, and maybe the next steps will be to have a more timely response to the information we're gathering.
Thank you. Breakout room 2, Drs. Michelle Schober and Courtney Robertson on pathophysiology.
Yeah, the biggest take-home points were that recognizing that we really do not have any direct proof that physiology in children, the information that we have from adults can be applied directly to children. We know enough now that at least the substrate for the pathways that are described in adults exist in children. Clearly, the developmental aspects of this and the impact on children should be different. And direct comparisons between the proportions of sort of manifestations present in children versus adults are not possible, but they do seem similar. So those were the biggest questions in the chat, comparing adults and children in terms of physiology and presentation. Courtney, would you add anything to that?
No, I think it's a great summary. I mean, I think we just need more information, especially related to the brain-specific developmental aspects that may play into differing neurologic manifestations if there are differences.
Thank you very much. And breakout room 3, treatment, that was Dr. Juan Roa.
So one of the main points that we have in terms of diagnosis and treatment is how the pandemics and knowing that different neurological complications can arise from COVID-19 was the awareness of having to look a little bit more into neurological manifestations of different diseases in kids. Because one of the things that happened with the pandemics in general was that right now, we discuss a little bit more about, for example, stroke in kids. This is something that we know in our main practice that is more common than we think, but with the appearance of different neurological symptoms in COVID, we can look a little bit more into that. So the people have more awareness into these different kind of manifestation, neurological manifestations. That's one of the things that we learn from the pandemics is try to look a little bit more into neurological symptoms in kids and assess them very well in terms of vascular disease. So this is one of the things. The other thing in terms of treatment is that for sure, we don't have a specific treatment for these neurological manifestations. So we have developed some guidelines for treatment of multi-inflammatory systemic disease, and some of these can be applied to neurological manifestations. And what we learned is that we don't have this specific treatment for those. So what we are doing is kind of treating the symptoms, the whole symptoms, and it will give you a little bit of or more accuracy of how to establish the pathophysiological changes of the different neurological manifestations. So what is the clinical scenario that you are accounting into these patients? It's something that is mainly inflammatory, is something that is mainly infectious, or is something mainly vascular or endothelial. And in that way, you can choose what will be the best treatment to go for this kids. So you will have to know exactly what the pathophysiological changes are in this patient, and also with the help of the accurate neurological exam, it can give you a little bit more of accuracy on the treatment. Because another thing that is important in terms of diagnosis is that we needed to enhance a little bit more our clinical capabilities in terms of how to diagnose neurological patients. Most of the times, it didn't give you the time to go for an MRI or for an EEG, or you don't have the resources for that. So that's why you have to be more true in the way you do neurological exams, and then assess the pathophysiological changes, and then you do the treatment in terms of these three different clinical approaches. That's something that we learn in terms of treatment.
Thank you so much, Dr. Juan. I think that's fantastic. Also segue into one of the questions in the chat. If we could spend 30 to 60 seconds talking about post-acute sequelae of SARS-CoV-2 or PASC. There's really few data in children so far. However, the data that are available in adults and children suggests many of these symptoms are neurological. And people are asking where families can get care for children that are experiencing these problems after having an infection, whether it was a severe infection or a mild infection. Dr. Juan and Pablo, can you comment on that in South America?
I don't know you, but we actually don't have this kind of follow-up clinics or that we can go for those kids. It would be great to have them. But one good thing is with this, we do have the necessity of doing that. We know that we have to follow those kids, and we have to raise awareness and consciousness of that this is something that we need to do. And with few patients like the commentary we have on the chat in Jamaica that are doing that, they will give us an example of how to do it and what we have to do next for those kids. But we don't have in Colombia, we don't have it. And in Latin America, we discussed that. And this is not very common thing that you can find in Latin America.
I've been recommending to families to discuss with their primary care provider first, and then if they have access to a rehabilitation or neurologist physician, to follow up with them. There are some groups like at Johns Hopkins that have pediatric post-acute care clinics that do telehealth, and maybe they're amenable to reaching out. So I think the vital next steps have really come out of all those breakout rooms, and were highlighted in the cases that Dr. Juan's been showcasing. Countries, leaders need to invest in infrastructure, treatment, and collaboration for pediatric-specific preventative treatments, including vaccinations, viral therapies, and to facilitate international collaborations to show that these problems need to be addressed in children. We should be able to rapidly deploy short case report forms and bank samples so we can better understand pathophysiology that Drs. Robertson and Schober talked about to save lives and normal development. We need to eliminate healthcare testing, vaccination disparities. And finally, data are not yet available on the impact of the pandemic on child health and development. It's important to assess ongoing symptoms, neurologic and otherwise, function and quality of life, what the impact is of loss of school closures and loss of life experiences, potential for increased exposure to maltreatment and loss of family members due to COVID and other problems. those were really the end of my comments. I have a lot of gratitude for this opportunity. Any last words from Dr. Roa and Dr. Vasquez Hoyos?
I think one thing that we learned from this is to strengthen our networks. So we right now we know that we share the same problems. All the time have been like that. But right now I know that even though we have in the US or in Europe or in Africa or in Asia, we will share the same problems and we can strengthen our networks because of that. This is the experience that we have here in Latin America with LARed. During the pandemics, the LARed group grew enormously. And this is something that right now I know I can find the answer everywhere. I know I can go for someone who has the answer in a different country than mine, and he's sharing the same problem that I do have. So this is something that we learn and we strain our network because of that. So I hope it will keep growing, and this is an opportunity for that. This is the example of how the pandemic have changed kind of our practice.
That was brilliant. Dr. Pablo?
No, I basically agree with Juan. What we need is networks, and that's what we're aiming to try to feel that physicians, not necessarily research investigators, can do research networks with clinical information so we can work together and find answers to what are our questions, which is what we do with a patient that has some signs of symptoms. And we're trying to do a better work at follow-up, which at least in my country is very difficult to follow.
Thank you so much. Dr. Michael Benedict?
Oh, thank you. It only leaves me to say a huge thank you to Professor Fink and all of her colleagues, and thank you all for joining us. We hope to see you next month.
Thank you. Bye, everyone.
Thank you.
Thank you very much. See you guys.